Hello, my name is Dr. Ponda Mutsipedi, and I'm the Vice President for Global Medical for General Medicine here at Amgen. Amgen is one of the world's leading biotech companies, and we're also a proud sponsor of today's Health Equity Summit and have been honored to be part of the planning process. Making vital medicine is a key component of Amgen's mission to serve patients, and the pandemic has certainly highlighted the need to advance health equity. And here at Amgen, we're taking action. We're taking action to help expand and achieve equitable health for all. One of our strategic pillars to achieve health equity is to ensure representative product development with the objective to expand access and improve our participation in clinical trials, especially in disease states that disproportionately affect racial and/or ethnic minorities. So we look forward to continuing our partnership with you and all the other stakeholders on solutions that will really reduce disparities and improve health outcomes. Thank you so much, and I wish you a successful and productive meeting.
Good afternoon, everyone. I'm Dr. Tanisha Carino, and I'm a proud member of the Board of Directors for the Alliance for Health Policy. During this next session, Spotlight Conversations on Equity in Healthcare, I'll be hosting a 25-minute lightning round discussion with a range of our amazing panelists and on a variety of topics. Each of these discussions is going to take the same structure. Each of our panelists are going to reflect on the challenges we see, why we need to meet the moment now in a sense of urgency. They're going to also tell us about what are the promising ideas, practices, policies that are already out there. And we're going to end with some practical advice to the health policy community for what we can do to advance better policies moving forward. Remember, you can also join today's conversation on Twitter using the hashtag AHPS Summit 21 and follow us at Health Policy, at All Health Policy. As a reminder, materials for this event are located on the left-hand side of your screen with the Agenda tab. Please select the session to view details in the extended speaker biographies. You may also submit questions to our panelists or seek technical assistance via the Q&A box on the right hand of your screen. We'll be answering audience questions towards the end of this session and try to pepper them in along the way. So first, I'm joined by Yasmine Long, who's a director at Faster Cures, a center of the Milken Institute, for our first spotlight conversation, inclusion and innovation. Yasmine's expertise is in health disparities, equity and outcomes, clinical research, patient and stakeholder engagement, and social determinants of health. Prior to joining Faster Cures, Yasmine served as the co-director of the Health Policy and Leadership Fellowship Program at the National Academy of Medicine. She also served as a program director at the Patient-Centered Outcomes Research Institute, PCORI, where she led a variety of programs to advance patient and stakeholder engagement in patient-centered outcomes research and in comparative effectiveness research. Yasmine, we're so pleased for you to join us today. Let's jump right into the discussion. So the COVID pandemic has led to the kitchen table discussion in every family for how clinical research is done, its pace, the uncertainty, and how do we trust what we see. And we're really coming up with a variety of challenges as it relates to the public's trust for clinical research. Help me understand what challenges we face and what are some of the promises that we see on the horizon. Oh, I think you're muted.
Lives these days. Oh. You're on mute.
Okay. Perfect. We've got you now.
Okay, great. So I do want to thank the Alliance for Health Policy and Sarah Dash and her team for inviting me to speak at the Health Equity Summit, and it's a pleasure to be moderated by you, Tanisha. So thinking about representation and thinking about building trust, we've become more aware in many ways how there is a legacy of mistrust that continues to exist in research and in our healthcare systems. And this mistrust spans multiple decades and generations, particularly among, but not just limited to, racial and ethnic groups. And we must recognize the intersections and the root causes of inequities, which has led to mistrust in research and the lack of diversity in biomedical research and innovation in clinical trials. The unfortunate part here is that we lose the potential impact of research outcomes and new innovations, because if the research lacks representation from underrepresented groups, then the outcomes of that research will be limited to how wide that net will be cast, right? So, in other words, it leaves gaps in how generalizable, novel biomedical research and innovation can be. And I'll just say that the equity movement is top of mind right now. And we, as leaders and experts within health policy and biomedical research and innovation, must address health equity as a call to action for us to change the culture of health systems and how we do biomedical research, and for policy change.
Yasmin, as you're speaking, I think one of the things that really rests with me is this has been a very long-term problem. We've been doing clinical research for a long time. Why is now the sense of urgency we see in addressing clinical research and the inequity we see, the lack of representation?
You know, that mistrust or the distrust or this building trust in this, I think, is a key component. You know, it often discourages some racial and ethnic minority groups from seeking or participating in clinical trials. However, but by not including more underrepresented communities and populations within the health innovation and research space, then we lack equity in how that research is conducted, and also in the standard processes and operating procedures needed to conduct that research. So we need more attention to diversifying the health and research workforce. And I know this was also mentioned and discussed in previous sessions in the summit. This could potentially serve as a mechanism to build trust. And when care providers and research staff look like the community that represents those who are studying, this within itself could serve as a mechanism to achieve health equity, as well as build trust in those communities to participate and engage in clinical trials. And I'll just say that, you know, clinical trials have been used for decades as the primary way researchers determine if a new treatment, like a drug or medical device, is safe and effective in people. But because clinical trials often do not represent the population suffering the burden of diseases being studied, this impacts how products are developed for the health consumer. So we need research to be representative so that we know the kinds of treatments and therapeutics that are safe and effective to use. And by underrepresented populations, we're also talking about older adults, pregnant and lactating women, people with limited access to technology, rural populations, people with rare diseases, in addition to race and ethnicity, gender or gender identification, and people with limited or low health literacy. So these are all considerations when we think about equity, when we think about how to diversify and have more representation in clinical trials, and also how that leads to the policy development and change.
Yasmin, I know you have a paper coming out later this month that might be relevant to this topic. We'd love for you to share a few highlights. And in doing so, you know, I think there's so much agreement, whether it was our colleagues at Amgen that just talked about us right before we got on about like the goal of expanding representation in clinical trials. Help us understand, is it a matter of just simply raising awareness? Is it financial incentives? Are there structural barriers to what we've seen? If that would be wonderful for you to touch on as well.
Sure. I mean, all of those are components. And at Faster Cures, we have a report coming out soon as an outcome of a multi-stakeholder effort. We convened an advisory group of thought leaders and experts across academia, disease-specific patient organizations, industry, patient advocacy, and policy to really dive deeper into these issues. And I want to reiterate a multi-stakeholder approach. I think that's one of the key components to really driving change. It's going to have to take everyone in the ecosystem to be at the table to do this. So with this work, we seek to serve as a catalyst to change the culture of the systems within biomedical research, to focus on the value of diversity and representation within the clinical trials enterprise to achieve health equity. And we are doing this by pinpointing concrete actions and strategies for greater diversity in the execution of clinical trial planning, design, recruitment, and enrollment, and addressing the importance of diversity and inclusion in the health workforce, focusing on board governance and diversity in executive C-suite leaders, as well as an academic researchers, diversity among principal investigators, and clinical research program and operations staff. So we hope this report will be a tool for understanding the issues toward addressing health equity across research and policy, with a focus on diversity in clinical research and trials. And the report will include recommendations to make meaningful change. And I'll just say lastly, it's our hope that this report will help key decision makers in positions of power to reform how we do research and implement health equity across research and policy for the long term.
Thanks, Jasmine, for that preview. I love hearing that we start with governance, right? We start with who are the decision makers that are making decisions about clinical research, whether it's a research funder like a PCORI, NIH, philanthropies, or whether it's the industry, and how do we have greater representation of both on the funding side as well as the investigator side. And then you've just touched on this idea of operationalizing trials. I think when I was, studying clinical research in Johns Hopkins, I always imagined like clinical trials happened in institutions that look like Johns Hopkins, in our top academic institutions. And those is where we trained the vast majority of clinical investigators. What are we seeing today? Are we starting to be more inclusive? Growing up in a small town in Alabama, I don't think any person I met was ever in a clinical research study. So how do we capture the numerous people, millions of people that don't live by an academic medical center?
As someone who in my career, I started out as a program coordinator for clinical research and clinical trials that happened to be at Johns Hopkins, there were a number of things. One, I did notice that the leaders of the research, the principal investigators of that research for that particular study, they ensured that their staff was diverse, was actually, and back in those days, not to date myself, but it was going into the community with the papers.
Like paper records.
Oh, yeah. Collecting specimens, processing, all of that. Okay. Phlebotomy, all of those kinds of things. So, but there was attention paid to who were the people who were collecting that information and going into the community. And so there was attention paid to that. I think that there is more focus on that now. The researchers at that time were pioneers and still are to this day. But thinking about some of the things that have changed, at least what I've noticed throughout my career at this point is, it's critical that we prioritize community engagement in health equity and research and apply and reiterating that multi-stakeholder approach, but that includes involving the community. So traditionally, and in some of my experiences in being that program coordinator or program manager, we do the research, it leads to a publication, and the outcomes of that research are not returned back to the community in some instances. I think that is really changing. That has changed over the years, so that the community gets to know what the outcomes of that research were. I do want to highlight a personal example. I remember enrolling a participant in a trial, and the participant said, "Oh, well, I see the results of the research." And I thought to myself, I didn't say this out loud, but I thought to myself, well, no, you're not, and you're not because you have to have access to this academic journal. And then you also have to understand the language of academic writing and such. And so thinking back to those times and now, I think that there has been some significant change in how we involve communities and those that are focusing the research on. So no one lives in a bubble, so to speak, too. So I think focusing on building equity in research has to also address societal, environmental, and economic disparities that are barriers to health, such as discrimination, poverty, access to employment, and other determinants. And those things impact if a person can even show up to a trial, or have transportation to go to a trial, or even have the literacy capacity to understand what they're doing in the trial. So I think that all of those components are important when developing research plans and having the community at the table to help bring that perspective forward.
Thanks, Jasmine. And I also want to reflect, like you were in full interest of disclosure, I'm on the board of governors for the Patient-Centered Outcomes Research Institute, and and as Jasmine is an alumni, I mean, there's such a focus now in patient engagement and really understanding deeply what that means, and not just as patients as a participant in a trial, but this idea that biomedical innovation should be aligned to the outcomes and how patients view themselves and their own care and their own burden of disease. We have seen over the last couple of years with the creation of therapeutics for COVID-19, with the creation of vaccines, all of this really coming together, where as a biopharmaceutical industry, there has to be more of this focus, and there has been over the last decade, around engaging patients and seeing what we can unlock when we really truly listen to patients. Reflect to me, because I know Faster Cures has done a tremendous amount of work in the area of COVID-19 and vaccine development, therapeutics development, but how has that coalesced to create even more urgency on what we know works? What is working and what's not working, and help us, give us some of the good hope stories that you're beginning to see with some of the silver linings you all have found.
Mm-hmm. Faster Cures has been doing this work for some time, and PCORI is, I would say, as an alumni, is certainly at the forefront for ensuring that patient and community engagement is a requirement for funding. I think that's a huge step, and I think that that's something that should continue. That, for example, your research plan has that community engaged approach to it, or how that those outcomes are going to be disseminated back into the community for impact. So in thinking about patient and community engagement, it's not just people being bobbleheads at the table. We really must engage across these groups. And when I say these groups, community leaders, patient advocates, disease-specific organizations, engaging across the net. I mean, everyone needs healthcare, and attention to our health is important for everyone. So I think we must meaningfully engage across research to achieve health equity, and that includes diverse principal investigators and attention to who are we enrolling and accepting into our programs. Also who is on the board governance, who are the executive leaders, and is there diverse representation there in order to make sound decision making. So thinking about research as a way, not only just a continuum of care, but also as a part of the community, and valuing them for the expertise that they bring with lived experience. So again, I think that not only is something that we've been seeing over, I would say, at least the past decade. I could be underestimating or overestimating that, but I think that is here to stay, and perhaps that will be something that will continue to be intertwined into how we develop policies for research, as well as research that focuses on health disparities, for example.
Great. And so you have a wonderful, vibrant community of health policy folks on the call today. We are entering a very active season of policy making here in Washington. What do you see on the horizon are some of the most important pieces of policy or practices that you might see that are really important for us to begin to scale or to move forward?
Yeah, I think, understanding the policy levers is a key component to drive initiatives to create change. And there's a need for policy incentives for health equity. Two that come to mind are the draft legislation for the PIC Act, which is the diverse and equitable participation in clinical trials initiated by Congresswoman Ms. Chu, focusing on rectifying the long and deep inequities in our healthcare system and clinical trial and research system. So that's you're seeing some actual development here and focusing on this. And I think that with the Cures 2.0 or the 21st Century Cures Act, another draft bill that to include how we diversify clinical trials, how we develop them, and such. And then another one, another policy lever I would say would be the proposed ARPA-H, the Advanced Research Projects Agency for Health, which would focus on increasing diversity in clinical trials and health disparities research to build a stronger and more equitable research ecosystem for all. So I think these are two really important potential policies that are in process now. And I think that they could really drive a meaningful change. So really do need to start at the policy level, and then perhaps let that trickle down into setting a foundation for integrating that across all policies within health and as well as research.
That's great. Thanks, Jasmine. I want to invite the audience. If you have any questions for Jasmine, please, as a reminder, just drop them in the chat. I also wanted to also remind us when we think about and talk about the clinical research infrastructure, that also goes beyond clinical trials. And there's a big acknowledgement that we need more real world data. Like, how do you see sort of the urgency around real world data? What does this actually mean? And how does real world data may help us bridge the gap between the lack of representation we may see in trials, but what we can collect outside of the setting of a clinical trial?
I think, the COVID-19 pandemic, there were both challenges with drawing conclusions from evidence that was not generated in a rigorous and randomized way. And, necessity of being able to learn as much and as quickly as possible about disease and treatments, and using real world evidence and data is to drive equitable changes and conclusions and how new policies around health equity are developed. And data collection, for example, I think is an important key. And also a focus on, specifically on thinking about data collection and real world evidence, thinking about talking about collecting data on race and ethnicity, thinking of those racial and ethnic subgroups, right? I mean, when we think about different racial and ethnic groups, they are not monolithic. And so when you collect the data, whether it be randomized clinical trial data, real world data, or evidence, which will RWD and RWE do help to speed up outcomes and research outcomes, but really looking at how we collect the data, how it's aggregated and used across platforms in order to not only drive equity and change, but to really capture elements of data that we might not have captured before. And I think real world evidence and real world data really can help to sort of tease out those areas that are, quite frankly, overlooked in data collection in general, particularly in clinical research.
I really appreciate your perspective. I mean, as a former researcher, there's only so many questions that we can ask in one study, even though there are a multitude of data that we can collect or continue to collect, that we can answer additional questions. And so hopefully not thinking just about clinical trials, which are so essential, but the infrastructure behind data collection, the role of real world data. And to the point that you made earlier, engaging a much broader group of people, whether it's rural physicians, others, to be champions of what it means to participate in clinical research. I really appreciated your perspective, Yasmin. I wish you the best of luck on the release of the report. We look forward to seeing what that says, and even more granular level, what we can do about closing the gap in representation in research. And thank you for your time today. So we'll be taking a short 5-minute break, and then we'll be picking up with the next spotlight panel, representation in clinical practice and medical education. Thank you, everyone.
Hello, everyone. My name is Della, and I serve as the head of U.S. Government Affairs and Policy for Alexion. We focus on transforming the lives of patients and families living with rare diseases and devastating conditions. At Alexion, serving our communities has always been integral to who we are and what we stand for as an organization. While the COVID-19 pandemic exposed many of the inequities that exist within our healthcare system, these disparities are not new. We believe a critical factor in addressing these inequities is the ability to foster a culture of diversity, inclusion, and belonging. Alexion is committed to building an inclusive environment where people belong because of their uniqueness. We recognize that nurturing the diverse perspectives and strengths of our people translates into innovative breakthroughs for patients. Additionally, in February of 2020, we launched the Alexion Charitable Foundation. This was fortuitous timing, putting the foundation in a position to quickly mobilize to help individuals and families impacted by COVID-19 and support organizations working for equity and inclusion. We look forward to continued collaboration across the healthcare ecosystem to identify and break down barriers in order to effectively build solutions to support better health for everyone.
Welcome back, everybody. We'll jump into our second spotlight session, representation in clinical practice and medical education. I'm joined by Dr. Jewell Mullen, who's the Associate Dean for Health Equity at the Della Medical School in Texas, as well as an Associate Professor in the school's Population Health and Internal Medicine departments. Jewell also serves as the Director of Health Equity at Ascension-Seton to help meet Health Equity's goals across its system. Dr. Mullen is an internist, an epidemiologist, a public health leader, and the former Principal Deputy Assistant Secretary for Health at the U.S. Department of Health and Human Services. Jewell, we're so pleased to have you join us today.
Thank you, Tanisha, and thank you to the Alliance for letting me lend my voice to this conversation.
Well, I'm really excited. With your track record, I feel like you're the best person to talk to share with the audience why it's important to have diversity and representation in our clinical care and in our medical workforce. So let's start there. What does that actually mean, and what are the challenges that we see today?
Thanks. I want to start with this because sometimes I tell people, you know, I have this title, Associate Dean for Health Equity, but don't take that to mean I'm really an expert in diversity, equity, and inclusion. And I just wanted to say that at the outset because we're having a conversation with the Alliance for Health Equity and we're focusing on DEI. And without diversity, equity, and inclusion, we can't fully achieve health equity. So they're very related. And I hope to touch on both points in this conversation. And so then going into the clinical environment, what I would say is we really have a tremendous opportunity to think now about how much our system has not worked for people because we have not had sufficient representation from the groups of individuals, populations by race, ethnicity, ability, gender, age, that really inform us about how best to care for people. And some of the challenges for individual patients in that clinical realm have related to the barriers to care, access in the fullest ways possible, diversity and inclusion. Really hard to say that you have that if we're not communicating with people in their preferred language, in ways that they want us to also express that we have some understanding of their culture. We have lots of opportunities to do better there. And from a policy perspective, we can be guided by Office of Civil Rights language around communication to really say across our organizations, are we doing that well? And then as health educators to say, are we teaching our trainees in undergraduate and graduate medical education to do that, which means we probably have a generation of faculty that haven't been taught properly. So there's a lot of faculty development that has to happen along the way. In the previous conversation, you talked a lot about data. Somebody said to me yesterday, health equity, you always want to make things better. I focus on health equity through quality. You can't do quality work without data. And a colleague said to me, why are we always focusing on what's bad? How do we know everything is bad? And it was sort of that pushback and defensiveness that sometimes comes when people are told they're not doing everything as well as they ought to. But the fundamental issue is, if we don't have data about our own performance, how do we really know that we're doing as well as we want to pat ourselves on the back and believe we are doing? And so probably in every conversation over the past 2 days, data might have come up in one way or another in terms of helping us know what we can keep doing well and helping us really hone in on what we need to do better. I hope I'm answering some of your question.
You are, Dr. Mullen, like Jewell, when I think about data and I think about health equity, we oftentimes look at data about disparities, right? Unexplained outcomes that are different because of race, socioeconomic status, rural, urban. But we're talking about medical education and clinical practice.
Yes.
So connect the dots for me. When we're thinking about that data, like what's sort of the flip side to that when it comes to thinking about the structural barriers to medical education or the structural barriers to clinical practice?
This is a perfect opportunity for all of us to be clearer about our conversations, to think about how to make a better health system. I'm a public health person. I'm a doctor. I'm a former bureaucrat. I'm a former medical director. So it's easy for anyone's head to swim when we think about how much we can celebrate that people who work in health and healthcare understand social determinants of health now and can say those 4 letters, SDOH. But one of the challenges, to get to your question, is that in our empathy and focus on caring for people holistically in their communities, many in the health system, in the medical care system, have pivoted away from our accountability for good medical outcomes. We need to be able to marry both of those, which means that while there may be some people who will always be able to say human and social services are very important to everyone's well-being, at the end of the day, inside of a medical system, we have to really look and say, are we controlling hypertension? Are we more concerned about making sure somebody's not going to have a readmission for heart failure? Or are we more concerned about getting them out quickly because of the incentives?
That really, for me, resonates. You know, I've served on the board of a federally qualified healthcare center, but they are not just a healthcare center. They also offer legal services, food services, advised on housing and social work. And when I hear about, for those of us that are in public health, the healthcare community talking about social determinants of care and what we do to improve health outcomes, it's exciting for me to see those bridges back to the other parts of our community's lives. What has prevented us? We've known that primary care needs to encompass the whole health of a person and the limits of medicine, right, and healthcare in our 4 walls. Like, what has limited us, and why is now the moment for us to transform? What's making today urgent?
The urgency is reflected in the suffering and disease that we see across all communities. All communities. I'm in Texas. I'm in Austin. We're a healthy city, but we're not. It just depends on your zip code. I'm in Texas. We're a healthy city. A lot of Texas is rural. There's a lot of despair there that we don't even see. There are so many people in the health and healthcare systems, and we don't have one system, so I'll keep saying both words, who have the heart to do the work and who are constrained by the policies that determine how they get to work. The notion of
dig in there. What specifically comes to mind for you?
Payment. I'm a primary care doc. Then I decide, okay, low on the totem pole in terms of prestige and compensation. Then I went into public health, lower on the totem pole for 2 of the disciplines that are so fundamental to population well-being and individual well-being. But our reimbursement policies and payment policies undervalue those. Not only does that mean people don't get the care, it also means that we drive a workforce away from what, in my view, should be fundamental to everyone's well-being: good primary care and a really strong public health infrastructure. So we have opportunities both at the state and federal level to do something about that. Those are big challenges. And then alongside that, payers, whether they're public or private, can also push all of us to do a better job at driving quality. We can no longer abide having a two-tier system of acceptable benchmarks for quality of care, depending on whether or not you're commercially or privately insured. And having just read this week that HEDIS is going to take 5 measures and start disaggregating data on them by race, ethnicity, and language, gives us an even better opportunity to say, within any payer, how are we really doing across population groups? Am I answering your question?
So not all of the audience might understand what HEDIS is. Would you like to explain, for those that are not in the quality mafia, what is, I always called it the quality mafia, what is HEDIS, and how could quality measures unify what a community is doing to drive better health outcomes, rather than us looking at our communities as commercial lives, as Medicaid lives, as uninsured lives?
Sure. So I'm going to say we all work because we want to do good. And we're all in these conversations because we want to make people better and give them opportunities. So what's the effectiveness of the care that we deliver? Healthcare effectiveness, HE. Okay, the data information system that helps us measure how well we're doing in delivering on good health and opportunity for health. HEDIS, Healthcare Effectiveness Data Information System. That's what that is. And so then you set a standard for, you look at how well are you doing caring for the people that you say, whether it's controlling their blood pressure, whether or not it's getting them their preventive, their screening, mammograms, et cetera. And then, okay, well, if the goal that we never really achieve is 100% of people could have the best, well, where are we? And what do we set as where we need to be? Yeah. From a standpoint of equity, right, we want everybody to have the potential to be at the top of what we set. Mm-hmm. But we won't know we're getting there if we look at numbers that collapse everybody into one denominator. Yeah. And then don't really think about who's inside. I hope
who can take action differently. Right.
Yes.
So I want to take us back to medical education.
Yes.
So those of us that went through our graduate and professional training programs, it's been a while, and I would bet that there has been some real progress as it relates to medical education. And we've also learned so much about what leads to a diverse and an inclusive and an equitable workforce. There are DEI professionals out there that are helping every organization hopefully do better and perform better through it. What is the opportunity that you can still see as it relates to medical education and really helping our next generation of physician leaders be ready for the diversity of the patient populations they'll see in the future?
Everyone who employs or hires someone to do diversity, equity, and inclusion work in their organization needs to see that person as a member of their senior leadership, see that person as someone who should expect human resources and others to work alongside them, and understand that they lead work that is the obligation of the entire organization. And those individuals who are then sometimes called on to present the data on how much diversity there is in an organization need to receive those data from other places. Yeah. That's part of it. Another part of it is to understand, in my opinion, that diversity of your senior leadership should not be found only when you get to the person who has the title diversity.
Right. Yes, we touched on this idea of governance in our last spotlight discussion as well.
Yes, and that's really key because diversity, equity, inclusion, the D is just one piece of DEI. Okay, the inclusion piece and the equity pieces imply that people who do that work, or people who come from minoritized and underrepresented groups, can hold any of the other jobs in a governance structure as well. And that's really important because, I understand what it's like when you really have authority over determining the strategy, the transformation goals, the business model, and how the budget is configured, which doesn't necessarily fall to that person. And then the inclusion piece, though, is even without the senior leadership, sometimes we look outside of our organizations when we realize we're not diverse and go to community to help backfill the other insights that we don't have inside, sometimes forgetting that people who work for us also live in those communities. So we can build the cultures of inclusion that help us know that if, from an organizational perspective, if we're trying to improve systems of care, quality, and performance, that's a whole organization effort that needs to be guided by leadership, but that everyone needs to buy into. So it can't be top-down dictation of such goals without talking to the others about, one, what they are, but two, helping figure out the best ways to achieve them.
Those are great points in terms of how we build our organizations that take responsibility for the health of our communities. This may be a little bit of a tangent, but I have to ask. So we have seen just an enormous increase in telemedicine since the pandemic, and a lot more latitude in terms of what we've been able to do in this public health emergency. How do you view the future of telemedicine? Is it a positive solution for us as it relates to getting representation in clinical practice? Like, is there an intersection to our discussion today in the role of telemedicine?
Sure, yes. I think it's another tool and a potential solution, especially for the people and in the places where it will work. In Texas, well, this is last year's statistic. In Texas, last year, 30% of rural Texans didn't have sufficient bandwidth, broadband access to really be able to use it. And so that can relate to consumers, but that can also then be have impacts on health professionals as well. So there are challenges there. So notions about supporting state and federal infrastructure for communication are really key. When I opened, I talked about the importance of communicating with people and meeting their cultural and language needs.
Yes.
That needs to be baked into telemedicine as well, too. That's really, really important. And I think we have even more to learn about how to do that effectively across diverse communities.
I reflect a lot on, when we first started talking about what is primary care in the 1950s and this radical idea of going into the community, right, and understanding what the community needs. Are we back to a renaissance of that when it comes to thinking about how we close health equity in our clinical practice? Who do you think is doing it well, and what do you see out there, whether it's health systems or health plans, government, state level, local levels? Where are some of the promise that we see?
I think I'm going to give a shout out to the efforts of HRSA and federally qualified health centers. And I used to be the medical director of a community health center, to the IHS, and to really think about not only the models of care that have been developed, that have, whether or not they're patient-centered medical homes, team-based practices, the willingness to say we value community health workers, even if a payer is still telling us CHWs need to prove their value before we pay for them.
Right.
I want to call that out, but I also want to call that out because even as we've looked at some of where the bright troubled spots have been through the COVID pandemic. I mean, we can look at places like Navajo Nation and really see what it's like when you sit back and let people in their community say, we know how to take care of ourselves. Some of that then means no, we haven't really gone back to the old days. Yeah, Dr. Swanson used to come to our house with his black bag, and we got our, and we got taken care of there. But that's different from showing up in a community, learning how you can be helpful, and really not even thinking you're engaging, but understanding that the power for change and improvement comes from the people who are most impacted. And the other part I want to add to that is, I hope it's different because there are so many health-related social needs that we now bring into the healthcare setting.
That's
but
right.
then we medicalize them. And
Yes.
Oh, so go on, you talk.
No, I'm just in violent agreement. Yes.
Yeah.
And, maybe as healthcare providers, we're not like the end all be all to address all of the social issues. Maybe it takes us being radical partners to others in our safety net communities.
Yes. And so when I was the public health commissioner for the state of Connecticut, primary care doctor, and, maybe some people thought a little bit of a contrarian, I also got a little bit concerned when people would come to speak to us, physicians would come to speak to us about scope of practice.
Yeah.
Because not everything has to be done by a doctor, spoken by this physician. And so that's an opportunity for us to think as well, especially not even just in primary care, but behavioral health, about what, not who people need, but what they need for the care that they require.
Yeah, and this is a factoid because I love your mention of both the Indian Health Service and FQHCs, but for those of you that may not know this, FQHCs actually have to be governed by the majority of the governance, and the individuals on the board have to come from the community and be patients of the organization. And having seen that transformation close up, it really does change the discussions that these organizations have about not just how they provide care and what they provide, but who's providing that care. So thank you. I have one final question. We're running really short on time, and you've already touched on so much of this as it relates to what's the action we can take as policy leaders moving forward. But if you had to pick two things that we can do differently, two things we can advocate and push for, what would that be?
So I talked about reimbursement. I talked about wanting to have people go, more people in primary care. Loan repayment.
Yeah.
More funding for people to actually be fully educated to do the work they want to do, but feel that they can't afford to do, would be one. And whether or not that's at a state level or at the federal level, that's one thing. And then even if that's through the National Health Service Corps, sometimes we acknowledge that we're asking people to go to health professions shortage areas that are more challenging environments. So to think not just about the individual who might choose to go there because they're from that area in the first place, but to think about what the capacity is, once again, to build up all communities to be better for who lives there. Because everyone who lives there wants to be in a thriving environment, not just the clinician that we hope would choose to go there. And then the second one that I would say is to continue to deepen, and this isn't all policy, but for every policy that will get promoted for data and data disaggregation, to create a culture of data collection that everybody sees they're responsible for. The former public health person in me knows that I relied on health systems to collect the data that then people thought public health had, but we had to get it from them. So there's a lot of work to do inside in learning how to ask people to identify their race, ethnicity, and language. And then to really get your providers to collect it. And inside your little health systems, not let the default response always be refused, because that's a really easy way to end up with inadequate data.
That's really great. I have one question before we wrap from the audience, and I invite you, I think we've got just a couple more minutes if folks want to add one more question, but the question that came in was, do you believe that cultural competency should be a required course in medical school?
So cultural competency or the different standards that are part of culturally, linguistically, and appropriate service standards should be, like health equity, interwoven through all of medical education. And if it's a required course, we have to teach the faculty if we expect the learners to learn. And then from a policy and health system perspective, we have to move from implicit bias training to bystander training to real institutional accountability to address issues when they arrive. Otherwise, the training doesn't matter.
Those are all great points. So in closing, you got a shout out from a Monique Daly, who's joining us from Wheeler, Connecticut. And I'd like to thank you for sharing your insights with us this afternoon.
Thank you.
And thank you so much again.
Thank you very much.
Bye-bye.
Bye.
Great. I think that we are going to take a quick intermission and we'll be right back.
Hello, I'm Shantanu Agarwal, Anthem's Chief Health Officer. At Anthem, we are laser focused on improving the health, not just healthcare, of our members and associates, and have positioned achieving health equity at the core of our innovation, partnership, and service to our associates, members, and the diverse communities in which we serve. Our efforts extend beyond ensuring high-quality care that meets the clinical needs of our members to also identifying and addressing their health-related social needs, such as food insecurity and housing instability, which we know adversely impacts whole person health. We are also investing in cutting-edge research that will accelerate the application of data-driven, culturally competent, and community-engaged solutions to address some of the most stark health disparities of our time, such as maternal health disparities. But we cannot do this alone. We believe that health equity is everyone's business, and so we are excited to partner with the Alliance for Health Policy. Today's summit could not be more important or impactful. All of us at Anthem extend our deepest gratitude to the Alliance, the leaders engaged in today's summit, and all of those committed to achieving health equity. I know collectively we are striving for the day when everyone has a fair and just opportunity to attain their highest level of health. Thank you.
Welcome back, everyone. Now we're going to go to the third spotlight, Families in Waiting, Birth and Child Health. I am joined by Usha Ranji. Usha is the Associate Director for Women's Health Policy at the Henry J. Kaiser Family Foundation. Her work addresses the impact of major health policy issues on women and girls, with an emphasis on insurance coverage, access to care, and low-income populations. Thank you, Usha, so much for joining me today.
Hi, Tanisha. Thank you. I'm glad to be here.
Thank you. So I think we all have seen the statistics, the shockingly around pregnancy and birth outcomes and the unequal outcomes that we see in American families today. Help us understand, what are the policies or practices that have been perpetuating these poor outcomes and outcomes that seem to be deteriorating?
Yeah, I think that the issue of maternal health and maternal health equity has gained so much more attention, and quite honestly, long overdue attention over the past several years. Part of that has been, the data that organizations, states, federal government have all gotten a lot better at presenting statistics, really compelling. But the truth is that these disparities have been in place for a long time. So it's also been a combination of the statistics and really putting faces to those statistics and hearing about some really tragic and horrible, mostly preventable cases of maternal mortality, but also a very large body of maternal morbidity. So that is something, that has finally caught the public's eye and caught policymakers' eyes. And the drivers are really complex. And they're, of course, like many of the issues we've been talking about through the whole summit, multifactorial. We're talking about, there's a lot of focus, I think, when it comes to maternity care, or historically has been, around the period of pregnancy and delivery. But the truth is, the health of women is a spectrum. And so if you look at the health of women before pregnancy, issues like chronic disease, and then access to care after pregnancy to be able to follow up, we have to really look at the continuum. And so, when it comes to some of the clinical drivers we know are related to heart disease, for example. But heart disease is a lifelong condition and needs to be addressed before pregnancy as well as after.
So tell me a little bit more, when you think about these various factors that are contributing to these poor health outcomes and these disparities. We talked a little about underlying chronic conditions like heart disease, but what are some of the structural issues or issues related to access to care? Do we see problems in terms of, is that one of the leading predictors for health outcomes?
Absolutely. So you can't separate the clinical from the larger issues. And I think that that's what maternity care in general shows us, that you really can't just, focusing on maternity care is really important, but we have to look at women's health across the spectrum and where it fits in the context of their lives, where it fits in the context of other public health issues, and where it comes, fits in with then raising children. So certainly, we know that, and there's been a lot of both quantitative and qualitative research that has documented racism, discrimination, and how that has been very embedded in the medical care system. We've been talking about it throughout this summit, but we've seen it very much when it comes to maternity care as well. And that was a long under-discussed issue. It's just, just about a year ago, the CDC actually finally initiated a campaign called, Listen to Her, which was just really the need to re-educate, sort of reform underlying issues in the medical care system of listening to patients in the maternity, during the pregnancy, postpartum period as well. And that in itself, because we know so many of these cases of mortality and morbidity are preventable, that really listening to the patient and what she says about her symptoms, about what she's feeling, can help alleviate. But I think another, sort of underlying factor that I work on a lot when it comes, and I know we're in a room full of, folks interested in policy, is our payment system. And I think that sometimes we don't think about that enough. The Medicaid program, I can't talk about maternity care without talking about Medicaid. The Medicaid program finances almost half of births in this country. In some states, it is over half. And in particular, Medicaid finances more than 6 in 10 births among Black women, among Hispanic women, and among Native women. So it plays an outsized role when it comes to maternal health equity. And I think there are a lot of changes that both at the federal level and at the state level that policymakers are working on to help strengthen Medicaid coverage for when it comes to maternity care.
This really is a great reflection of the discussion we were just having with Dr. Mullins, where we talked about the role of payment, but also the role of cultural literacy and listening to patients. Are we seeing that? What do we see in terms of the workforce that's available relative to good maternity care? Is that one of the factors that we're seeing is another driver?
Yeah, well, I mean, there's certainly, there's sort of, it happens there are a lot of different levels when it comes to that. So if you think about some of the issues related to maternity care and poor maternal health outcomes have to do with just access to providers. And that in some communities, disproportionately rural communities, we've had closures of OB units at sort of a very high rate over these past 10 years, disproportionately rural communities and disproportionately in states that have not yet expanded Medicaid. So just women's access to providers is certainly very uneven across this country. We have, there's a number of groups who I'm sure on the meeting who have, sort of documented, quote, obstetric deserts. That's part of it. But there's also a lot of work to be done around changing the workforce, diversifying it, broadening it, better access to community-based providers. There's Medicaid does have coverage for midwives. It's not available in all areas or certain community level groups. Another area that has really gained a lot of attention is inclusion of doulas, or support services during pregnancy and that postpartum period into Medicaid. And how do we do that? Right now it is only a few states and a few locales have experimented with that. I think the results have been somewhat mixed, in part because, there's policy change, like including doulas, but then there's also the issue of payment and really making sure that providers of all across the spectrum of OB work are compensated at a rate that they can really provide the care that they want to provide and that patients have access, but also, setting up new providers like doulas, setting them up for success, compensating them so that they really can provide the high quality care that they all want to.
I really appreciate when you started, the conversation was really about how do we improve health outcomes during sort of the pregnancy. But really, this is about extending that perspective, not just in pregnancy, but child health outcomes.
Right.
Tell me a little bit about how we're doing related to child health outcomes. And for people who may not have a strong foundation in this topic, how do we think about the link between mom health outcomes and then child health outcomes?
Yeah. Well, I think that there is, a large body of research that has shown that when it comes to infant health, early childhood health, it is so integrally tied to mom's health. And, honestly, if you think about some of the work that again happened around the Medicaid expansions for pregnant women, they were really driven by decades ago, very sort of sky high rates of infant mortality and huge disparities, again, with very high rates among Black populations. We still have very large disparities when it comes to infant health, but there is, that was a impetus for a major policy change that expanded eligibility for pregnant women. What we see right now, though, still decades later, is we still have a huge cliff when it comes to eligibility for pregnant women as opposed to moms. So particularly in states that have not yet expanded Medicaid, what we see is that 2 months postpartum, we have many new moms who fall off of Medicaid because their incomes are above the thresholds for parents. So we haven't fully integrated, that connection between, the sort of continuous spectrum of care that women need to take care of themselves and to take care of their families.
Yeah. So walk us through that. So women reach the cliff. They're no longer eligible for Medicaid in some instances. And then where's the child coverage at that point? How complicated does this become? Sure.
Well, I think one really bright light is that infants we know, who is particularly born to, as Medicaid covered deliveries, infants are eligible for coverage for the first year of life. And so we have again and again, eligibility levels for kids and for pregnant women are higher than they are for parents. But in a state like Texas, which has not yet done full Medicaid expansion, what we have is new moms, say a new mom and her partner who, first-time parents, she would be covered for Medicaid through that 2 months postpartum. But then if they have a household income that is above $4,000 a year, that is considered, quote, too high to remain on the program. So the baby would be covered for the first year, but mom might fall off at 2 months because, they might have income above that. And also then there's in terms of getting private coverage, that might just be unaffordable.
And having been a new mom twice over, the complication between mom health and the baby's health is so tightly fused during those early periods of time for this insurance coverage to really play such a strong role in defining health outcomes, not just for the mom, but babies. This has been an issue that has been, long front and center. I appreciate that so much of this has come from the amazing work around data and storytelling that your organization has really been on the forefront. So thank you to the Kaiser Family Foundation. When you think about today, like, why do we have a window? Is this an issue that we may have more bipartisan support because it's something that we can all agree on? You know, why is our window of policy now, in your opinion, or is it not now?
Well, I think that this is, I've certainly never seen this much attention on issues of maternal health and outcomes. And I think there is a growing understanding of all of these intersectionalities. And I think there's deep desire to help to recognize, that the health of moms, the health of babies is a harbinger of so much else in our healthcare system, right? And that stemming these inequities is crucial. It's foundational. So I think that understanding has become broader. Another issue that we are starting to see just in this week, at the federal level, we have a congressional committee. We have a bill that proposes universal paid family and medical leave. I don't think I can't remember the last time that we've seen a policy like that move forward. Obviously, we don't know if it's going to be enacted anytime soon. That's still to be determined. But I think, again, that is, when you think about the health of children and parents, we still have, one of the surveys has shown that a quarter of moms return to work within 2 weeks after giving birth, in part because we're one of the few countries in the world that doesn't have a paid leave standard, and many people just can't afford to go any longer without pay. So I think that, the changes that I've seen, we do a lot of research around state policy and state Medicaid policy. We're certainly hearing a lot of interest from the state policymakers to make changes to help improve maternal health outcomes. Obviously, we had the American Rescue Plan that passed earlier this year, which made it easier for states to extend that postpartum period from 2 months to 1 year. Again, really kind of understanding that postpartum is, we all know that goes beyond 2 months. So paving the way for any sort of, for easier policy change in that area, but also about, things like paid leave, which again encompasses so much more than the maternity period and really speaks to the, sort of supporting families to raise their kids after pregnancy.
That's great. Oftentimes we have this notion of like, what's in it for me? So when we don't address the disparities that exist between maternal health and child health that we see today, like, how does it affect every American family? How does it affect all of us? And how do we connect the dots to people who may not realize that this is part of a health of a community?
Yeah, well, I think that's exactly it, that it is, I've found that most people are really touched in some way, that they are, close to children, they are close to parents, even if they aren't themselves parents. And we are talking about, and I think that's why it is has been so compelling to make the case that, the maternal health, the pregnancy period is in part just the beginning, both in terms of longer term health issues for parents, but then it also speaks to raising children and raising families. And that is, something we all do live in communities. And so recognizing and understanding that, this is maternity care is a really critical period for a lot of people, but that it is, keeping it in the context of larger reproductive health access as well as larger healthcare access, and that it can be a real entry point to making our communities in general stronger. For some people, the period of pregnancy might be the first time they have regular ongoing care. So it's such an opportunity to then be able to address issues that might be identified and help keep people healthier and stronger after pregnancy.
That's such a great point.
Benefits us all.
That's such a great point you're making. When we think about some of the most promising areas and practices that are out there, and we've talked about the ability of states to expand Medicaid coverage past past the typical deadlines. What else do you see out there that you're full of hope for?
Yeah, well, I think, it's hard to separate any of this from the pandemic, obviously. We are living in new times and we're all adjusting. But, and so if you think about what was happening last year, there was, on the one hand, sort of a shutdown of, quote, non-essential services, non-essential care. And there's a lot that goes into that phrasing, but I think, if you think about for people who were pregnant and for people seeking care, that there is, for those who, had children last year, who gave birth last year, there was suddenly, sort of some drop-offs in just access to social supports. And I think, so I think that is an area where I'm hoping we can now take some of those lessons and really make some changes going forward in terms of how do we help, secure that those supports are in place. The other thing I think that the pandemic brought out for us that I think is an open question still is this rise in use in telehealth. And I think there's been other sessions during the summit so far around that. But, telehealth has also been incorporating or being more incorporated into obstetric care. And so, but I think we want to really keep an eye on equity, very deliberately keep an eye on equity. If we are going to increase use, maintain the world of telehealth going forward for women's health, be it in terms of lactation support, in terms of postpartum access to postpartum contraception, prenatal visits, we need to make sure that we keep an eye on one, ensuring that people have access to, the ranges, the types of services that best suit them, be it in person or telehealth. Most women express desire for both when we do our surveys, but also, which payers are covering those services and who has, which providers have funding to be able to shore up those services. Are we seeing inequities? How do we make sure that we don't build inequities as that world grows?
That's right. Well, Dr. Mullen made a great point that, we talked about telemedicine and the workforce and its role in narrowing health equity or advancing health equity. And the reminder that not every place in America has got great broadband service. So,
exactly, just at its most fundamental level. And so, is it a replacement for traditional in-person care? I think that's all yet to be seen, but just recognizing its most basic level that not everybody is starting from the same point.
Absolutely. Well, I want to encourage the audience to absolutely put in your Q&A. I'm getting a battery is running low. So I'm going to ask my awesome little helper who's with me to find my battery pack in my purse. But with that, Usha, when I think about maternal and child health, this is an area where there's an amazing opportunity at the federal level. We've talked about Medicaid policies at the state level, but who are the other actors in the system that need to be galvanized and brought into a conversation around improving maternal and child health that we think are maybe non-traditional?
Yeah, absolutely. I think there are so many. I think you have to start with, there's a whole range of community-based providers who are on the ground and, work with, support, and are, parents, birthing people who have lived experiences. And so I think solutions need to be really community-based. And that can be, again, there's, we've talked a little bit about doulas, but I think groups like home visiting partnerships, our public health community, it's sort of funny to me, or not funny, but odd to me that, how much, and part of it is the natural, sort of flow of the everyday work. But sometimes we work, we all know this, in really, silos. You'll have, kind of healthcare financing and public health folks that are, kind of on different paths. Again, all kind of really came to a head, I think we saw in the pandemic. But if you think about, nurse family partnerships that, some of whom have really great on the ground experience. And so how do we take that knowledge and work it into developing policies that, really support, people wherever they choose to deliver, wherever they choose to get their care, be it in federally qualified health centers, in hospitals, in birth centers. I think also, even just I do a lot of work just sort of in the spectrum of sexual and reproductive health. But sometimes, there can be sort of artificial divides between maternity providers and providers of other sexual and reproductive health services.
Right.
But, how do we help integrate those so that, particularly as we have this opportunity now to really, I think, kind of, maximize and make the best use of the postpartum period. There's a lot of really great energy around that. How do we help ensure that, folks have access to, primary care, chronic disease, contraceptive services if they want it, sort of better integrating those. And I think again, a lot of that really has to start with community level work. And I will just mention
that's a theme that
one part of maternity that gets that I think we don't also talk about enough is also around fertility care and fertility assistance, and how do we shore up access to that? Because the truth is there is very little coverage in Medicaid and in private insurance for families, for people who are looking for fertility services. And that kind of, honestly, it kind of categorically excludes certain groups of people, be it somebody who's single, be it, same-sex couples, or just anybody who needs fertility assistance. But that's something I think that isn't yet woven into certainly the payment systems.
Well, you make a point that I think every panelist has made too, which just resonates with me, that so much of the actual improvement that we need to focus on, whether it's medical education, clinical trials, and maternity and child health, really do happen at that local level. That as policymakers, we can set a framework that allows for the creativity and the innovation that needs to happen at that ground level with the actors that people are turning to. And whatever that looks like in these communities. You raise a really great point. Like, there are so many new ways that we all are becoming parents, whether it's through surrogates, adoptive parents, not heteronormative families. How do we begin to think about not just maternity care, but like parent care, right? Like, how do we shift from or extend ourselves in what we've learned about how to improve the health outcomes of new parents and children to the wide variety of ways that families are forming?
Yeah, I think it's, really, doing more work sort of earlier on. I think, we've talked a little bit, we've heard in the earlier conversations about thinking upstream and how important that is. And, being able to talk to all people, including men, about, what their desires are, what their, interests are in terms of raising families. And like you said, sort of family care, and bringing in everybody into this conversation. And I think, I do see that happening. I certainly hear in the clinical world, I attend some meetings with clinicians and I hear them talking more proactively about that. I certainly think, in the family planning world, there's been a lot of push around, in terms of quality guidelines, ensuring that everybody has conversations with their providers about what their family planning needs and wants are.
That's great. We have two quick questions from the audience. The first one is, what are your thoughts on maintaining continuous eligibility in Medicaid and CHIP and the importance of addressing health disparities, maternal and child health?
Yeah. Well, I certainly think, like I said, I think when it comes to equity, again, Medicaid covers more than 6 in 10 births among Black and Hispanic women. So, and certainly, this is a great, I think this is an opportunity for states, but states do have to take up the option if they are interested in doing this. And so I think that, I think it's an opportunity. I think, that for states that are not doing full Medicaid expansion, which I would just want to say, also comes with a very high, a higher federal matching rate. I think that a lot of states we've seen have expressed interest in doing this, but not necessarily all of the non-expansion states. So I think it's an opportunity. I think we have to see which states choose to move forward, and it will be available for 5 years. So, and it's, the sort of most, it is one of the sort of largest changes that we've seen at the federal level. Again, the House bill that's currently underway would actually propose to make it mandatory. I don't know if there's the political appetite for that. I think we'll see that in the next few weeks.
Thanks, Asha. There's one more question. How can traditional large health systems partner better with FQHCs to improve maternal equity?
Yeah, I think that's a really important question, because I think that sometimes the inpatient and outpatient worlds don't always, they don't necessarily always work together, and not because of any malicious reasons, just because of the practicalities of sort of how the structures are set up. So I think it has to be very deliberate. I think, again, thinking about that continuum for prenatal through postpartum is an area that I know the quality improvement groups are working on, but I think it's starting. I think that, and that's why I mentioned areas like other parts of sexual and reproductive health, like contraception or family planning for those who want it. That something like that could be the bridge.
That's wonderful. So I know we've run out of time. Isha, thank you so much for joining us today. And I hope that you have a great rest of the day. And thanks for fitting us into your busy schedule.
Oh, thank you so much. It's a real pleasure, Tanisha.
Thank you. And for our audience that's listening, we are going to be moving on in just a few minutes to our final spotlight conversation for this afternoon: translation, action, and state policy approaches. Thank you.
tricky balance.
Hi, everybody, and welcome to our final Spotlight conversation this afternoon, translation of action to action state policy approaches. I'd like to welcome our colleague Hema Tewson to the discussion today. Thank you so much. Hema, are you on with us?
Hi, Tanisha. Yes, it's Hema Tewson. How are you?
I'm good. And before we begin, I just wanted to make sure that we reminded everybody about the materials again for this event. They're located on the left-hand side of your screen with the agenda tab. And so please select please select the session, and then you can see everybody's extended speaker bios. And you can also follow us on social media, on Twitter, and ask follow-up questions using the hashtag AHPSummit21. So with that, I am joined by Hema Tewson, who is the Executive Director at the National Academy of State Health Policy, a nonpartisan forum of policymakers throughout state governments, learning, leading, and implementing innovative solutions to health policy challenges. Hema joins NASHP, excuse me if I got that wrong, from the Duke Margolis Center for Health Policy, where she's been a leader of the center's work on emerging state policy issues, included COVID-19 testing and containment, vaccine distribution and education, coverage and health system reform, Medicaid, and addressing equity within and beyond COVID-19. Previously, Hema served as the director for the health division for the National Governors Association Center for Best Practices. Hema, we're so happy to have you join us. I don't know if you want to say a few words before we jump in, or whether we want to just go ahead and jump in.
Oh, I just want to say thank you to the Alliance for having me at this really important meeting. Equity has been the center of our work here at NASHP, and so really interested in talking about what's happening at the state level.
That's so excellent. And I love that we're ending with you, because in every discussion we've had this afternoon on these spotlights, it has all come down to what's happening at the ground game and how do we enable and empower communities to help address some of the health equities that are in their communities, and what's our role as federal policymakers, state policymakers, and the private sector with that. So with that, as states are opening back up and doing so with less than ideal budgets and fewer staff than before the pandemic, can you give us some examples of how states are executing innovative and equitable approaches to get back on track?
Sure, and I'm happy to talk about this in sort of two different buckets. I think the first part is, how have states really been responding to equity in the context of the pandemic? And I think there's a lot that we've learned there, and so I do want to share that. And I think the second piece is, with respect to budget, we have like a historic amount of funding flowing to states and localities as a result of the American Rescue Plan Act. And so I think there's some real, potential there to think about how to address some of these disparities that we know that exist in that context. So let me just start with the first piece, what happened during the pandemic. And I think, I always like to look for silver linings. I think one of the silver linings of the pandemic is, and I think you've heard this in the previous speakers, it's at least state attention on health equity is at an all-time high, given the disproportionate impact of COVID-19 and, frankly, the national reckoning on racism across the country. And so many states, or at least some states, had started work on equity before the pandemic. But right now it's reached, I think, sort of a tipping point in our current climate. And there is a real interest in understanding and acknowledging the ways in which political, economic, and social factors impacts health outcomes. And I thought I could just talk a little bit about, in the COVID-19 response and what we really saw. And so I think all of us know this, communities of color faced higher COVID-19 infection and mortality rates, but yet those communities typically have not received the same level of resources. And there's a lot of different reasons for that. And I think in recognition of that, a number of states really tried to center equity throughout aspects of their COVID-19 response. And one of the examples I just wanted to share with you all here and in the broader audience is, there's been at least 29 states that set up task forces, offices, advisory councils, or subgroups that were really tasked with thinking about, how do we address the equity implications of COVID-19 on health and mortality, economic issues, and recovery. And part of the role of those groups was to engage communities. And I think that's really where, frankly, my work at the state level, a lot more can be done is how do we bring sort of the voices of community into sort of the actions that states take? And you can't have every person sitting at every table, but really understanding the needs of local communities and understanding how those policies can impact them really does make a difference. We hear
can I ask, building on that?
Sure.
So and I know you can't crystal ball the future, but are you sensing that for the states that have set up these task force, specifically about the pandemic, that there's an energy to expand that beyond just the pandemic response? Not that we're over the pandemic response, but are we seeing other issues that are being brought up within these contexts that have to do with the broader healthcare system or the health of the community?
Yeah, and I think we're seeing that in a couple of different ways. In the context of the COVID-19 response, we saw with respect to testing and PPE and states trying to figure out like, how do we really direct these resources earlier on? And they looked at like things like social vulnerability indexes and sort of identifying where can we understand like the local need for resources and try to like blend that into their policies to make sure that they were directing, testing and PPE. And then, once we got to vaccinations, that was the same sort of challenges there. And I think there are a number of states thinking about how do we sustain some of the work that we're doing here beyond the pandemic. And I, we can sort of move into that part of the conversation now. And I think that's through governance structures. So we've seen a number of states really think about, okay, how do we create sort of sustainable change with respect to governance? And I think that can be in a few different ways. We've seen a number of states recently hire or in the process of hiring cabinet level positions for diversity, equity, and inclusion. And I think that's a really important step. And I don't want to underemphasize that. If you really want to sort of infuse equity in all policies, you have to have leadership at the top within state government that understands what's needed and is able to actually influence. And so, for example, I'll just talk about Virginia. Virginia actually codified the position, which means that it doesn't just exist because a particular governor decided it was important. It's governor after governor, and it's funded by the legislature. So I think that is really key. I think the other piece is, there have been 7 states and the District of Columbia that have declared racism as a public health crisis. And I think, some of those states are then figuring out, okay, what are the next steps after making this type of declaration and what comes next? But that's, again, a fundamental step in terms of identifying, okay, like where are we going to do the longer term work on addressing disparities that go beyond the pandemic?
Amy, I really appreciate you bringing up the idea of governance, because that's another theme that's resonated is representation in the work we do and how we deliver healthcare, but really at the leadership level at the top being really a critical aspect. So I know it's probably early days for some of these task force and this idea of identifying racism as a public health challenge for us. Yeah. You must see some really amazing range of activities that are being at least attempted. We may not know whether they work, but when you wake up in the morning and you read through your emails, like what gets you excited? What was the last thing that you're like, wow, this is pretty incredible?
Yeah. So, okay. Recently I've been really focused on like, how are the states really thinking about, in addition to governance, like spending funding that they're getting right from the federal government? It's a historic amount of funding coming from ARPA. Is it going to places where we feel like it's going to make a difference on equity? And here at NASHP, we're conducting a 50-state scan to understand, okay, where is the money going and how is it going? And if these are in different places, some have decided they're spending it all, some are still deciding. But I just wanted to share this with you because I think it's exciting. There's themes, I think, across like how do we infuse equity in telehealth, behavioral health, housing, education, childcare? How do we address language access services? How do we think about supporting hard-hit communities, including businesses that were owned by historically underserved groups? And how do we close disparities in wealth, education, access? And I'll just give you some specific examples so I can put some more flavor to what I'm talking about. So Massachusetts, for example, allocated $1 billion for housing, including $200 million for programs that aim to close the wealth gap. Georgia is proposing equity-focused services such as addressing health disparities, investing in housing, addressing educational disparities, and promoting healthy childhood environments. New York is thinking about working with minority-led community development financial institutions to ensure economic recovery for women and minority-owned businesses, and using the CDC's Social Vulnerability Index for funding allocations and program evaluation. So I could talk more and more, but just to give you a sense of like the types of activities that states are thinking about. And I think these are the types of activities that we really need to double down on and make sure that they have the ability to grow and actually have impact.
Those examples are so incredible to me, right? Because in the earlier discussions we've had today, we've talked about sort of the limits we have within healthcare to address the health inequities that we see. And you've just given us such great examples, whether it's access to capital and what New York is doing, whether it's housing, which I heard a couple different times. Like, these are areas that we all acknowledge are part of keeping communities healthy. And, you know, until I think the most recent days, we haven't really thought about that as a response from a health policy community. So that's really wonderful. You know, I had cut you off. We had talked about governance, but what else are you starting to see at the local levels? And I appreciate the fact that you all are collecting a lot of great data, so you'll be able to report out over time what really was the full inventory of how states used additional monies and what's working and not working. And I'm sure states really appreciate being able to share these best practices as well at this period of time. But are there other types of policies that you feel like have changed, or ways? And I love the idea of not just the task force, but the way that they are trying to really engage differently with communities. And what does that look like? And how do people learn from the challenges or the opportunities of doing that?
Yeah. And I there's a couple of examples of states that really have tried to embark on this work even before the pandemic. And I think it really helped them during the pandemic of really engaging with communities. So I just wanted to talk a little bit about those, because I think it'll sort of, again, like paint a picture of, I think, what's possible. So just to talk a little bit about Rhode Island. In Rhode Island, they developed health equity zones, and that was really to equip like specific geographic neighbors and communities to collaborate to create healthy places for people to live, learn, and work and play. And I think they were very creative in their funding. I mean, they created a braided funding model to invest in community-led projects to build more resilient communities and build community power to sustain the work. And those types of projects have led to, like, you know, focusing on preventing chronic disease and improving birth outcomes and improving the socioeconomic and environmental conditions of a neighborhood. And what was really interesting during the pandemic is this structure had already been set up before COVID-19. And it really helped them, I think, sort of double down on how do we get the resources out to the communities and know where there are gaps and what they need, whether it's testing or PPE or vaccinations, where there's gaps in education. And so I just share that because, you know, not every state has this exact model, but I think it's a way to think about how a state-led initiative can really engage communities. I'll offer one more example because these examples excite me.
Can I ask a little bit more about that? Because I love this, and we've been talking a lot about, you know, how do we lift up a community, a place-based solutions, right? Because we all belong to a place, and the intersectionality of the issues we see in healthcare and other issues really play out at that level. So I love this idea of Rhode Island setting up these zones. But when you say braided funding, for the audience that may not understand what is braided funding?
Yes. So it's bringing, like, you know, whether you have money from grants, federal grants, local grants, and then philanthropy, you know, private businesses. It's bringing a lot of different types of resources together and making sure, okay, you know, we all know we're all paying for different things in different ways, but let's look at it holistically and see how we can actually fund an initiative. So it's not just Medicaid paying for it. It's not just philanthropy paying 100%. It's actually making sure that we can best leverage resources together.
So different sources of capital, but do healthcare dollars have to go to healthcare providers, or is it even more expansive than that?
It's more expansive than that. You know, for the zones themselves, I mean, there's public health money that flows. And so, you know, they had, during the pandemic, there was money that flowed from like the CARES Act, you know, that helped identify how to get work done in the equity zone. So it doesn't have to be a payment to a healthcare provider from, let's say, a Medicaid agency. I think it can be a lot more fluid than that and more broad thinking in how you actually implement.
And if you had to analyze, like, why Rhode Island? What was it about Rhode Island that made developing these zones, the braided funding, even a possibility? What's the secret sauce?
I think it's leadership. I think it's leadership and really relationships at, different community levels, and really having the will and the interest to actually do something like this and spend the time. It's not easy work. State government isn't designed to build a lot of, individual braided funding and community partnerships. You have to kind of really put the work into it to get that done. And I just think, reflecting on it, it's from the top to the bottom was an interest in doing this, and that's why it happened.
Well, I have a real interest in this example, because I hope that it creates a lot more resilience for those communities moving forward on whether the issues are health equity, the next pandemic, obesity, mental health. Like, having that infrastructure just sounds so promising. So I had to dig in deeper because a lot of curiosity. So you had a second example for us.
I did. And so in Oregon, they have really set a goal. They created an Office of Equity and Inclusion within their Oregon Health Authority at the state level to really help operationalize health equity and, train state employees and develop equity leadership among state employees. And they actually want to use what they call coordinated care organizations, which is really essentially they service somewhat health plans across the state and different regions of the state to provide services to Medicaid enrollees, to actually, make sure that they're able to be incentivized to address equity in their work with providers in the community. And they, as part of that initiative, they also have engagement with community through governance committees and advisory committees and operational feedback that goes bi-directionally. And I call them out because they have made a large investment. It's a very robust team, and they want to eliminate health disparities by 2030. So
wow. They've set like a goal.
They set a goal, and they want to measure their progress, which I think a number of states are interested in, is like, how do we measure progress? And I think, frankly, that question should extend beyond states. That should extend to sort of all of us here, and in different levels of the healthcare system and beyond the healthcare system. But anyway, they, I think, are identifying, look, like, we have this goal, we have to start measuring where we are. What does that mean? I mean, does it mean, there's increases in the health by looking at, who's getting better, who's diabetic and has congestive heart failure? Does it go to other areas about, like, addressing housing needs and educational needs? I mean, you can go really far and broad. And I think this is a question I think we all need to think about, is like, how do we start measuring progress? And I know early in the conversation we talked about data, and data continues to be a challenge. At the state level, where I work, it's certainly, there's been an increased focus given sort of the COVID-19 pandemic. We need to get better race and ethnicity data. We need to understand our communities. We need to understand where there are gaps. But then, even beyond that baseline, which needs, a fair amount of work to improve, we have to also figure out, like, what are the policies that are actually making change, and what's the baseline by which we measure ourselves by? And I think that's a lot of work that needs to be done, and a lot of thinking that needs to go into that. So I say that as a call out to all of us that care about this. It definitely needs to be a collective effort.
That resonates with me so much, because we've talked about metrics across all of our discussion, right? You only improve on what you're measuring, and the power of a collective community of people, of stakeholders, being able to say, this is the problem we have, but we're also holding ourselves accountable through the metrics we collect. I mean, that is only the beginning of the conversation for where then you do invest. I always have a difficult time seeing, you can't jump to almost an investment question without having a common set of beliefs as to, like, what's the problem. So that also really resonates with me, and probably many folks in our audience. I know we're getting towards the end of our time. I want to invite the audience, since I've been so intrigued with all of the different examples, to ask any questions you have in the chat. And while we're doing that, we are talking about state. We've talked about even localities, or these zones that are much even more micro than a state. What's the role? What do you anticipate is the best role of the federal government moving forward in that dynamic between the feds and the states?
Yeah, it's a great question. So, the feds obviously have already through Congress provided funding and are, thinking about what comes next. I actually think for some of these really tough questions, let's just take race ethnicity data. This is not just a state requirement or obligation. Providers collect race ethnicity data, health plans collect race ethnicity data. We have sort of a mechanism through census. OMB puts out standards. I mean, this is a much sort of broader question of how we think about race ethnicity data, where I do think, talking to the state leaders, more federal guidance is welcome and needed so that we can have sort of a more uniform approach across states, across localities, across providers, across plans. Who is responsible? How do we need to be thinking about this as a society, frankly? On some of the other pieces in terms of, making investments with federal funds and where are there opportunities for partnerships, I do think the federal government can play a role in holding up where they feel like they're really great models. Not that everybody has to do them, but, here's are things to think about. And here are ways that we feel like we're making success. That can be within COVID-19, right? Where have we really found like a bright lights? And let's share those. And so other states know how to think about it. And I just use that example because as we go into the next vaccine round with boosters and kids under 12, let's center equity in that response. And what have we learned from the first time around of what can work and where can we incentivize that this time around? And the federal government can really play a role in that. I think on the data side, like the IT modernization, again, this is beyond the states, right? The state, IT and technology really needs to improve, but so does a whole host of other sort of data sharing with the federal government, within agencies at the federal level, et cetera. And then I would just say, I know I'm you asked me this question, I have so many thoughts.
No, this is great.
Across federal agencies, and I know there's a real interest in this administration of thinking about this, but we're talking about things that are siloed at the federal level, and they're also siloed at the state level, housing and transportation and food insecurity and education and health. And so how can we, and I know there's efforts underway to try to think about this, how do we think about really blending those, whether, even if it's not pure federal resources, blending the thoughts and the policies, figuring out where there's possibilities for overlap and helping the states navigate that. Because that is tough. I mean, when you sort of have money coming from the federal government down, that's why the states kind of look the way they do too, right? They're reflecting, here's how we've originally gotten our grants and we've created these agencies this way. And so how do we at the state level try to sort of have a more cohesive approach, but that also has to happen at the federal level and have some help sort of figure out how to make those connections across funding streams.
So such a great point, because if we had really great data, then we have communities who are empowered to say, what is the problem that they really want to collectively focus on? And if we could do that, then whether it's the federal government, state government, private philanthropies, private sector, that gives a great signal to every source of capital for how they could be helpful in their communities. So I think this has been such a wonderful discussion. Amy, thank you so much for being part of the panel today. I hope you have an excellent afternoon. If you're in Washington, you're staying out of the thunderstorms and there is no flooding in your area. So with that, we are a wrap for this session. To our audience, we would love to hear from you. So please take a moment to fill out our evaluation. Don't judge me for almost running out of power. We got a plug in, so that did not happen. Open the survey module on the left of your screen to be able to fill out our evaluation. Your feedback is really critical to us at the Alliance to help improve and to continue to build on our future events. A recording of this webinar and all the materials will be available to you at any time in the Eventia platform. Join us for our final summit session, a fireside chat with CMS Administrator Chiquita Brooks-LaShore that's coming up in 5 minutes. So don't miss it, and make sure to click on the next event under Live Now in the right sidebar to join the next session.